I'd like to welcome you all to this session within the EuroScience Policy Forum, the first of its kind, which tries to address issues of importance to society and academia. So both on policies for science, but also science for policy, or knowledge for policies in a large scope. This specific session is called the Implementation Challenge Revisited. And the idea is to bring up the value and importance of implementation of knowledge and try to somehow maybe discuss and possibly influence the way that the decision-making structures in the world focus maybe slightly more on using knowledge that we know might be of importance and that might work, rather than only, which is often the case, focusing on the new, the novel, the innovative, which in itself is important naturally, but we believe that there is a lot of knowledge not being utilized to the detriment of society as a whole. So that was a brief background, and I'd like to also introduce today's panel. With us we have Professor Agnes Binagwaho, who is the Vice Chancellor of the University of Global Health Equity in Rwanda and a previous health minister in Rwanda. We have Kei Koizumi, who's the Chief of Staff in the U.S. Office for Science and Technology Policy, OSTP, at the White House in the U.S., recently appointed by the Biden administration. We have Dr. Anna Bergström, who's an implementation scientist at Uppsala University and Karolinska Institutet here in Sweden. My name is Carl-Johan Sundberg. I am one of the two moderators. With me I have Professor Nina Worms, who is a professor at the Royal Institute of Technology. We will discuss specific questions in this area. And the main questions we will address, and we'll see how far we digress or how much we focus, but this is the idea, three main questions. How can governments and funding agencies be convinced to put resources into implementation when innovation and the new is what is hailed in general? Second question is, what are the most prominent obstacles to implementation and which obstacles would be most useful to focus on? And the last question is, might we look to, for example, political sciences, diplomacy and ethics in finding solutions that are politically and practically possible and attractive to realize? Now, implementation can, of course, be of importance in many areas. And what I think we might be discussing today might include climate change mitigation, health policies, and possibly broader, because implementation as such is a generic term and process for many, many areas that is addressed by science and society alike. The program is set up in the following way. I'll mention a few things after these first slides as an opening presentation. We will have a brief summary standpoint where each panelist gets the opportunity to say a few words over a couple of minutes on these issues and just introduce themselves as well more deeply than I did. And then we'll have a panel discussion on question one, followed by some minutes of Q&A from the chat. And we will hope that a lot of you will comment and come up with questions that you find we either have missed or that you would like to re-emphasize. And we'll repeat this until we reach the end of time, in a sense, and then we'll summarize a bit. So we'll try to get through the questions. It says question 2 twice, I see. That should be question 3. And there's a lot to say about policy implementation, both at the practical level, on the floor, so to speak, but also at a more political or policy level. And this is just one reasonably recent publication from 2019, which talks about what the policy implementing policy structures should do or interact with. And here these authors have raised that there are, of course, the bureaucracies, the financial decision makers, political leaders, those that might benefit from change, interest groups of various kinds, but also what they call donors, which might be simply sources for resources that might help to make this true. And this is true especially in certain countries which are depending on external monetary and other resources. Just to trigger some interest maybe. WHO published in 2018 some key learnings, and this is a pretty complex figure, but what is health in all policies? And they took the example here of air pollution and just try to sketch out the fact that you cannot address the health consequences of air pollution, which kills a lot of people in the world annually, unless you address several facets of society. And that includes healthcare, but also a lot on the energy conversion that we pollute our world with, housing, industry, regional authorities, waste management, urban planning, transportation, and again then the health sector. So this is just to show you that this is one area, but this could be employed and enriched through any other example you might wish to bring up. So with that, I now hand over to our panelists, and I'd like to ask Professor Agnes to have introductory remarks. So please, Agnes.
Thank you. Thank you for having me for this important debate and discussion. And good morning, afternoon, or evening, whatever place you are in the world, because now this world, more than ever, is a big village. So we doesn't have to look very far to understand the importance of implementation. COVID we are in the middle of it, of the pandemic, and it's a clear example of implementation challenge. We know from the past health crises such as SARS-CoV-1 outbreak, what we were supposed to do to stop the spread of this pandemic. And the definition of a pandemic, to make it simple, it's an outbreak that it's not contained. We have the evidence-based intervention, such as wearing masks. We were told not to wear masks. Why? Because there was a shortage of masks, not because scientifically there was a reason not to wear a mask. And some countries have done well in the preparedness and response to COVID. Others no, while all knew what to do. And it was clear that the developed world was ready and should have passed through that easily. They didn't. Was it because they knew what to do? They knew. They didn't know what to do? They knew what to do. Was it because they didn't analyze correctly the contextual factors in their own countries? They didn't. They didn't analyze the fact that the trust in science and the trust in the words of leaders, and also the leaders' trust in science, was not there. And this has put a big delay that has allowed the virus to penetrate the communities from the beginning. So the challenge lies not in the lack of knowledge of what to do, is the lack of know-how to implement the intervention that has been proved scientifically right. So many countries had failed to understand the facilitating and the challenging contextual factors and to be prepared accordingly. And the key to solve such implementation challenge is to continue to invest in implementation science and to start to understand that implementation science is not only strategies or etc. It's something you have to do and have a systematic approach with. You have to analyze your context, identify the contextual factors that are facilitators and leverage them, and identify the contextual factors that are challenges and mitigate them. Have an approach that is multisectorial to respond to the challenge and to leverage the facilitation. And it helps bridge the gap between what we know and the implementation outcome we are working for. And this is not systematically done. It's totally neglected. And this is why the decision, the strategy that are selected doesn't fit the implementation challenge to overcome, to get the implementation outcome that we need. And that's why at the university where I am the Vice Chancellor, We train our students, doctors, nurses, and all the spectrum of those who provide service for better health for the population in an implementation science approach. And what you were saying about what is new, what is an innovation, has nothing to do with implementation science. You still have to understand the context and see what facilitates the implementation of those innovations, and what is an obstacle to that, mitigate that, and work with all the concern to make it happen. Vaccination. In many countries, you have access to vaccine. The people doesn't want the vaccine. It's a failure of implementation science. It's not a failure of knowing what to do. We need to create trust in the product. We need to create the distribution, etc. So we have plenty of time to discuss all this, but implementation science comprises analysis of the context, the evidence-based intervention to be implemented, select the strategy according to the challenges and the facilitators, and monitoring and evaluation to adapt all this. But without this approach, don't expect to succeed, or good luck.
Thank you so much, Professor Agnes, for that strong introduction. I now turn to Kei Koizumi, please.
Good morning and good afternoon and good evening, everyone. I'm Kei Koizumi, and I am a U.S. science policy practitioner. And I'm delighted to talk to you all today about the implementation challenge revisited, because we keep revisiting this challenge and it continues to persist. We're here today, of course, because we do possess technical solutions and scientific knowledge that could make our lives better, while at the same time putting less pressure on our planet, our global climate. And we keep adding to the store of scientific knowledge and technical solutions through continual government and private support of research and development. But I think it's valuable that we're here today to stop and focus on how we might work toward implementation of established solutions rather than on the innovation of novel ones. I would also frame it as a former economist. We have a stock of knowledge and a flow of knowledge. So I think it's important that in addition to building the stock of knowledge, which is what we need to do and what governments are organized to do well through the support of research and development, we should also ensure the flow of knowledge to implementations, to solutions, and to impact for people. So let me give my perspective as a government science policymaker and practitioner. The United States government is the largest single funding source for research and development in the world. And we face this challenge continually, so much so that we call it by different names. We call it the research to operations challenge. We call it the implementation challenge. We call it research translation. We also call it research to decisions challenge. That last part, research to decisions, is a problem because, as a governments, a lot of what they actually produce are decisions, policy decisions that will affect the lives of the people. So let me talk briefly about one of those, research to operations. The US government and other governments fund a lot of research that are designed to improve the ability of governments to provide services to the people. For example, in weather research, we invest millions, if not billions of dollars in weather research so that we can provide better weather forecasts and data to the people, including agricultural sectors and industrial sectors, to improve everything about life. So in an ideal world, we fund weather research as a federal government so that we are better at weather forecasting and delivering weather services to the people. We also do climate research. climate research, similar to weather research, but on longer time scales. We don't just support climate research to understand the changing planet, although that is an important reason. We also support it so that we can do better at providing climate predictions, local scale forecasts for climate change, local understanding of conditions, sectoral understanding of conditions, and also to provide climate mitigation and adaptation solutions. But that is a challenge. For the federal government, we are accustomed to supporting laboratories in doing research, but we are not as intentional, and most governments aren't, at making sure the results of that research then translate into practice or are implemented by a broad sector of society in solutions. And the government does have some handicaps when we're thinking about the research to operations challenge, because that challenge is somewhat less relevant when there are companies, because the profit motive and market incentives are powerful drivers for translating research results into some commercial product or service that is implemented in the marketplace. But for purely government implementation or non-market implementation, governments have to continue to play a role to correct for these market failures. How do we do that? Government as the market is one solution. When the government directly procures innovative solutions from research. Also, governments can directly implement research insights into improved health practices through government-sponsored or government-run programs. Governments can also do natural resource management solutions for public lands and waters. And in the policy community, we keep innovating. We keep innovating with ways in which we can extend the ability to turn research into implementation. One example that we've seen tried out recently is advanced market commitments, or AMCs. Advanced market commitments are guarantees for the government to pay for an innovative product that does not exist yet. We saw that with the COVID-19 vaccines, in which the government committed to purchase vaccines that had not yet completed clinical trials. We have government procurement policies in which climate neutral technologies for government facilities and vehicles are prioritized for procurement funding. We're experimenting with new ways to do old things. Most governments, including the United States, have had agricultural extension services for 150 or more years, in which we have dedicated services to make sure agricultural research is put into the hands of farmers and farming communities to have innovative solutions for agricultural problems. We have retooled that in the past few decades to have manufacturing extension services so that we can help companies implement research solutions that may be a couple of years old from the research literature, but have not diffused yet to small businesses. We also do proof of concept demonstrations using resources to demonstrate the value of established solutions, coupled with government procurement to push down the cost curve to make innovative solutions more cost competitive. We are using these strategies with clean energy technologies, such as carbon capture and storage, and solar power and wind energy. So in the United States for health, we use the phrase bench to bedside to illustrate how health innovations go from the laboratory bench to the patient care bed. But that is a research to implementation challenge, which has proved difficult in many of our nations. We continue to have challenges, but we also have some surprising moves. You no doubt heard that in May, the Biden administration announced that it supports waiving intellectual property protections for COVID-19 vaccines as countries struggle to manufacture these vaccines. For a science policy practitioner like myself, it's a novel policy tool. Usually, science policymakers try to strengthen IP protections to encourage more innovation. But this time, the US administration is seeking to waive IP protections for vaccines, not to encourage future innovation, but to boost the implementation of existing innovations or existing vaccines. And I know this is very controversial, but stepping back as like a student of science policy, I find this a fascinating twist on a standard policy tool. But experiments like this show that we have to be creative to reframe our innovation system slightly away from creating new innovations to ensuring that already existing innovations are diffused, implemented, and utilized. And the vaccine example is obviously healthcare. There are other healthcare examples. We are experimenting with pay-for-performance payment systems, which encourage innovations, often existing low-cost innovations, to deliver innovative healthcare solutions at lower cost than established practices. One tried and true implementation solution in healthcare is allowing health innovation patents to expire, allowing generic medicines, that is, established solutions, to be cheaper than patent-protected novel medicines. Another set of policies and programs that's had great impact is PEPFAR, the President's Emergency Plan for AIDS Research.
Okay, think about the time. So please carry on.
I'm sorry.
Not
Yeah.
too far. Go ahead.
So I'll close with PEPFAR as a true example of translating innovations into implementation across the world, including to people who would never have benefited from innovative medicines otherwise. We need more such innovations in research to implementation. So let's take the spirit of experimentation in research and have that same spirit of experimentation when we are creative in research to operations, research to implementation, and research to solutions. Thank you.
Thank you so much, Kay. Very good. And Anna, please, your turn. You were put in the game very, very late, so we have full understanding, but please, I know you know a lot.
Thank you very much. My name is Anna Bergström, and as introduced, I'm a researcher in implementation science since about a decade ago. I've lived in Uganda and in Vietnam, and since 2 years ago, I've also started to work in a high-income setting, Sweden. So I'm a bit of a rookie in high-income settings, but more experienced than from having worked globally. I mean, there are a few things that I would like to say as an introduction. And first and foremost, I've come to think that there is a semantic challenge when we speak about the no-do gap. I mean, very often in circumstances like this, we speak about the no-do gap. We haven't so far today, but I'm sure that people in this conference and in the audience might hear of it a lot. I hear it a lot anyway. And it's assumed that we all understand what we mean, but the more I've discussed it and also presented it in teaching, I think that there is a risk that people see that there is a gap that we need to fill with new things. I mean, it creates sort of an idea that there is a gap and we need to fill it with a lot of new things. I mean, there are things in my experiences to say that there are a bunch of not so well connected stakeholders in this so-called gap, and they need to be connected, and that should drive implementation. So rather than sort of trying to create a lot of new solutions, I think we need to think about how to use the available structures and to really get these stakeholders together much closely so that they can also work together in coalitions to create change and also not to create chaos or splintering of health systems. So there's something around the no-do gap where I'm a bit concerned how we use it and how people see it that I wish to raise. Another thing is that implementation, in the essence of implementation, it's about people changing behaviors. It actually assumes that a lot of people, each time you present them with new knowledge, they're supposed to change their behaviors. And then we can go to ourselves. And we know that changing behaviors extremely challenges. I mean, this is something we know from our own personal lives. And it's been assumed that new knowledge and new ways of working should somehow diffuse into health workers. But of course, that's not the case. They might not verbalize that they need the capacity to actually know how to change behaviors, but this is actually what they're subjected to all the time. And that's an extreme pressure to put on people, actually. I've met with lots of very senior physicians, and when we speak about implementing guidelines, they can come up to me after a few hours and they say, you know, I have been receiving guidelines in my emails by authorities, and I understand now that they are expecting me to change behavior. I mean, this is something that's been happening throughout their career without them really necessarily sitting down and reflecting that this is actually what it comes to. They want me to change behavior in relation to lots of things in this guideline. That's a challenge, and we need to reflect around that. I think what Professor Agnes was saying in the beginning, I mean, to really invest, and this is something also happening at Karolinska Institute that I know, where Carl-Johan is also working. We need to invest in the future health workforce to tackle new knowledge, because it will not stop coming. It's not like this is one change that's coming now. It will continue to come. So we need to build systems that are open to the fact that new knowledge will continue to come. And that's fantastic. I love science. But then we also need to make sure that there is end line users who are also available and ready to sort of manage that, all this new knowledge that comes. And also that training that they receive on how to implement and how to manage with change, that's also based on the best evidence on how implementation should happen. So they need to be trained also in thinking around things like behavior change, which is in itself a whole other scientific area. So not only then also later on to invest, for instance, in continuous medical education on clinical topics in health, but also to focus on how to use locally derived data, for instance, how to identify areas of improvements, how to find best practices, and also how to tailor implementation. Because that's what it comes to, building expertise in how to tailor implementation to, as Agnes was saying, and that we have been raising, I mean, that this relates to the specific context. You need to tackle the motivation and capabilities of the target audience, health workers, managers, etc., maybe sometimes also patients, and also optimizing the usability and understandability of these new methods. I mean, because you might think as a researcher, you come with an optimal solution, but no one asked for it, or you are not introducing it in the best way. So we need to also, as researcher, the research community has to think about how we are actually, like, how can we work more closely together with the end users so that we also develop and communicate our different innovations to the need of those we would like to use it. And this is about tailoring. And we need to, I think, there to also really invest in how to build implementation capacity. Then one of the, I mean, we will come back probably to a few other things. In reflecting upon the topic of today, I also realized that 10 years ago, there was, anyway, in my world, a discussion on how to disseminate knowledge. So how, you know, we should really optimize how we disseminate knowledge. Then it slowly shifted to how we should communicate and how we should engage in a dialogue. And now we're speaking more and more, and this is just in 10 years, how we co-create knowledge, how we early on in processes actually find people who are, you know, first listening to the ground, what challenges are there, not sitting in our castle in academia and developing things that no one is asking for, but really trying to understand what is needed out there and work together with the people who will be using. And maybe we need to be a bit, as scientists, a bit more flexible and pragmatic and use the scientific toolkit and answer the questions that people need us to answer quicker. And I mean, that in itself, because we know that in the end line, the health workers in the front line, I mean, they are tackling so many other things. So we need to be as flexible as possible and also speak a language and be open to the fact that they're experts where they are, and to find these, see each other as really experts. So I would say that in the rebuilding of health system in this post-pandemic era that, I mean, might start now, and we know that the post-pandemic era will continue for a long time because we're far from it. But there might be reasons to reflect a little bit on how to ensure the engagement of these different end user groups across the board and really facilitate the development of these coalitions. So have people, including like the communities that the health system actors serving, alongside politicians and health workers to really to see each other as experts and really identify the challenges where we really need to focus on.
Thank you, Anna. Am I audible? I think so. So with that introduction, which was both deep and broad, I think we should focus on question number 1. How can governments and funding agencies be convinced to put resources into implementation when innovation, etc., is hailed in general? The question is there a need for more money to begin with? And if so, how can we utilize that to address many of the issues you have brought up? So, Professor Agnes.
I'm going to be a little bit controversial. No, we don't need more money. We don't need more money. Just imagine a moment that we implement correctly all the knowledge we have already, all the drugs that are in cupboard somewhere or in the head or in the factories. We will save already trillions of people. Okay, can we start with that? So it's not a matter of money. It's a matter of how we do. We have, we have clinical trials that discover great health tools. And in the other hand, we have the health outcome we want, or we should fight for. And we have the tool, the private sector inject money, it became a product to buy. It's still not health. We need now to make the people take it. And everything what Anna says is there, but it's not directly what we can say it is implementation science. To the needs, we need to explore what is the need and prepare what we are going to do to solve the problem we have seen. And we can convince the government to do that. We help the government to find the contexts that are positive or negative and adapt the strategy to implement to turn that in health outcome. We show the benefits and we can tell you the benefits. When we say cost effectiveness, finance in a government is something that no government has enough money. So if you can show that you can save money, it's something that they will help. It will help. After that, we show how with this process you can reach the maximum with equity, some ethical principle there. The return in investment, and emphasize that we don't have enough people, but we can reach this outcome better in that way. And that's how I take the example of COVID. Some countries have done so well with little. Other countries have done so badly with a lot. We should start analyzing why. They don't take care about the context, etc. So,
yeah, Professor Agnes, just a question here, because it didn't say money. Maybe I mentioned the word money, but it's about resources. And one way to create resources is, of course, to use the existing resources in a more intelligent way, for example, by saving money. So what the question meant, I think, was how to create resources or possibly put in more resources. They may be in the form of money or different ways of working, focusing as well on how you...
Even human resource, even yes. Infrastructure, even all this, and come back again to this trauma we all have now with COVID. And I can tell you the example we did. We all know that people are scared to go to a center where contagious diseases are treated. So you may empty a structure you have and turn it in another structure. Is more changing the resources for better health outcome. And also you prove that if people doesn't die, what we had with Ebola in West Africa, that they were not trusting the government. They were not going to the health facilities. They were scared to die there. So they start delivering at home, etc. It happened also with COVID. So showing the government the outcome as human, you lose less people, you save the maximum of money, and you keep the health of your population better. So yes, you may call that whatever, they will follow you.
Anyway, we'll come back to the question about how to convince decision makers in question number 3, I think. So, Kay, any comment on this one?
Evidence-based decision, evidence-based policy, evidence-based strategies, science.
Always important, we believe. Thank you so much. Kay, thoughts on this one?
On the first question, I think, it's important to strike the right balance. I mean, extending our COVID example, I mean, we do still need new research. We needed recent research on mRNA vaccines to produce two of the leading vaccines in the world. But we also need to reorient some of our thinking and our resources to making sure that the results of innovations are disseminated, are used, benefit all of the people. And that's it's a difficult political problem, because, especially within the research community, because we know research communities, they are organized to pursue curiosity-driven basic research. So it's been a sea change to reorient to even have use-inspired basic research. What I think we do need is more need-inspired basic research and translation of research results into meeting human needs. Those are somewhat new concepts, though they've been around in some form for decades, but they do require attention. And we can support research such as decision science or implementation science or translational science. But really making sure that research innovations find their way to meeting human needs is not a scientific problem. It's a policy problem. Maybe it's a whole of society problem in which, new innovations are favored over existing solutions that have been around for years, but have not benefited all of the people yet.
We might take the example before Anna comes in about if you take prevention. And prevention is, of course, a very broad term that can be employed within infectious disease as well as in NCDs, non-communicable disease. But it's not really utilized, even though we do know from extensive research that it's much smarter to prevent a problem than to solve it once it's manifest. So that's just a reflection here. But also comment on your thinking there about let's say, target-driven basic research. I think that's important too. But I also believe that, which you stated, that the curiosity-driven science that really developed the RNA field, with people not thinking a moment about what this might be used for, but simply going after understanding complex phenomena. So you need to have a mix of all these. But once you have something which seems to be closer to fruition, then you need to invest, I presume. So Anna, comments?
Oh, this is okay. There are so many different threads, but I mean, first I want to touch upon. I mean, it's almost impossible to speak about anything without bringing up COVID, right?
Patrick, you seem to have something on. Patrick, your mic. Thank you. Go ahead, Anna.
Yeah, I mean, when it comes to COVID, I early on started to look at. I mean, I'm not going to go into comparing what different countries are doing. I do think that many countries are trying their level best to actually also make contextualized, tailored intervention. But I mean, health systems look very different. If we take Israel as the example of a very country that were quick in starting to vaccinate, they have a very centralized health system. So when things were supposed to be rolled out, this is what they could do. I believe also that's the case in Rwanda. You have a fairly centralized health system. Sweden is a very decentralized health system. So for us to even start making a lot of the recommendations or closing malls or whatever, I mean, we needed to change legislation in the country, and that's a political process and it takes time. So I mean, some of these things is also because we have a democracy in Sweden that that should take time for us. Governments are not allowed to only shut things down for the reason that you can have people in power that could start shutting things down for whatever other reason than in a pandemic. So we have those legislation things in place. We also have to understand those different political dimensions of how countries have managed the pandemic, because I think that that's also playing, at least what I'm seeing, that plays a lot into what we're seeing. But I do, at least when I've been discussing with colleagues, I think that many governments are trying their level best to really do something. But even the context of where we start, even the best things like making sure that people don't meet, that can be a difficult thing in a democracy where people are supposed to be able to meet and demonstrate, for instance. So I just wanted to mention that. Okay, so how do we get governments? I mean, my experience, my experience is that when I meet policymakers, and this might sound extremely trivial, I understand that, but when I ask them to read guidelines that even maybe their own institution have developed and reflect upon what it might be to sit and be the practice that is actually the receiver of these guidelines, and actually have them to play almost like a role play how they should manage this change, they fairly quickly realize that that's very challenging. I mean, getting access to, implementation is a fairly hot topic, or sometimes people are already fatigued by the word, but it's hot in the sense that you get an access to policymakers. And when you do, speaking of it and getting them to see it from the end user's perspective, in my experience, and them to really understand what it means to sit as an end user in this system, I believe that they are much more humbled with what it actually means to sit and be the one who is supposed to provide evidence-based services. So there's something about gaining access and also starting to speak the same language and having the same vocabulary, and also seeing this. I really think that seeing it as a behavior change challenge makes people much more humble, because we know from our own lives that even I know it's great to go out walking doesn't mean that I do that every day. So if you're now sending me a guideline with our 50 new recommendations, you can imagine what that means for the individual health workers out there, or someone who's managing climate change or whatever. So,
but Anna, may I ask you then, has this, let's say, sense of humility or humbleness changed the way that these policymakers might conduct their new development of guidelines and the implementation thereof? Have you seen that following, or are they just giving up because it's too complicated?
No, I do think because they are quite eager to actually also disseminate and contribute to it, in their role where they are. So I do think it changes how they do things. In Sweden, we have a new, I believe it's called the knowledge management steering, where we have different, groups, national groups that are developing guidelines on cardiac health and preventive services and et cetera, et cetera. In the beginning, they didn't. So the idea was that they should develop the best knowledge, like knowledge-based guidelines, national knowledge. That was terrific. But of course, within each of those groups, there should also be someone who's discussing and thinking about how should we now implement this if we're doing such a huge drive to gather the whole country. That was not there in the beginning, but I think a lot of footwork and a lot of implementation soldiers around Sweden have discussed with the different national groups. So they're actually starting to reach out and say, so how should we do this best for these guidelines not only to become desk products, but really to be used? So I do see that they are thinking and trying to read so that their recommendations are also formulated so that it's clear what people should do, and not in a fluffy language, and not having a million references. This is something that should be used.
Yeah.
So,
are you addressing what I think Professor Agnes in the beginning said, that there's not a lack of knowledge, but lack of know-how? Is this part of the know-how, Professor Agnes, the know-how of really understanding the whole chain of things?
Yeah, that means we know the what. We know the outcome we want, but many doesn't know the how to do it. And that's why I say that we should sit and reflect, because there are principles on how to reach the know-how. In situations that are changing, we don't know what tomorrow is, but we know how to analyze what to do tomorrow with what will come, and we don't yet know. We may not have the what and the solution, like we know that for an infectious disease, the best solution is a vaccine. We may not have it. But there are people doing research in that field that have the know-how to do that as fast as possible. But now the politicians, they have no excuse, Anna. I'm sorry. They are educated people. And they should know that we have to go through evidence-based intervention if we want evidence expected outcome. We should, the politics has a very bad, we have a very bad tolerance for that. It's a former minister who told you that.
But Professor Agnes, question number 3, which you often come to, and I'm glad for that, because you come to the, let's say, convincing of politicians, which could be easy, could be very tricky, and you have your own experience, which we will listen to intensely on question number 3.
But
so
you talk about it by humility.
Yes.
Humility. You don't know everything. So you
exactly.
call for each domain, you call the people who know. Sometimes they're in your country, sometimes they are not. But you have the humility to say, this is this type of problem, I have identified it, and call the people who can solve it. You have to go evidence-based, then you have the maximum success. And then you have the maximum economy. And sometimes to have economy on the long run, you have to accept to spend more. That's what Kay say, some investment. But we know that if you don't take care of the context, you will not make it. If you don't choose the right strategy, if you don't take what the science has already discovered, what we call the evidence-based intervention, you will not make it, except if you find new ones. But so that's what I say, they are principle, and politician has no excuse, no, except self-fitness and lack of humility.
Exactly. Thank you. That's a strong word. So I now turn to my colleague and see what kind of questions we might have from the chat.
Thank you, Karl-Johan. I'd like to invite everyone that are attending to post questions in the chat. We have one comment from Janet Herring that has to do with whether or not we are actually using expertise outside of academia enough in policy, or do we turn to academics, professors, researchers too much? Anybody want to reflect on that? You were saying, Professor Agnes, that the knowledge might not be in your country, you might go somewhere else, but are we talking too much to professors and not to other people who might actually know? Anna was also talking about this, so maybe one of you would like to respond to Janet's comment.
Would like the word?
Anna.
All right.
Go ahead, Anna.
No, but I think what I was trying to also say at the beginning there was, I mean, I think there was a link what Janet put in the chat, and I haven't followed the link, so I don't know exactly what that was. I mean, it's clear that there are experts outside of academia, and what I was saying there in the beginning was also that we need to identify who these experts are. I mean, in Vietnam, I was partly involved in a project where we got local stakeholder groups together who met every month and just discussed what are the local challenges, and try with the local politician, a local village health worker. I mean, really local people. These people don't normally speak to one another, but they're definitely experts in where they are. In 3 years, ladies and gentlemen, neonatal mortality reduced by 50% by talking to one another. So clearly there are lots of different experts. That's not a matter of what you were coming into, like resources and money. These are experts. So the community health workers and the representative of the Women's Union, which is a national organization in Vietnam, I mean, they were people who could really lift and say, these are the challenges that we are facing. The politicians were the ones sitting on the cash and could actually divert money into what they were needed to instead of making decisions. But normally they don't have communicable channels there. I mean, they have lots of meetings in Vietnam. It's extremely...
But Anna, Anna, somehow this happened. And the question was, why did it happen 3 years ago and not before? Was it by chance or through your project, i.e. external stimulus or resources?
It was very much as it was very much as a consequence of the project. Because what these people, I mean, you can't expect people in a very hierarchical system, which every system, I mean, we have different roles, right? Academia, you have companies, you have politicians, etc. These people, for them to sort of to work within those structures, but still make sure that people are spoken to and being enabling that they speak to one another in a respectful manner, and really making sure that everyone listens to everyone. You need someone else. So what we trained were actually lay women who were they were experts in facilitating a dialogue locally. But they were lay women. They got a very short training, but from the recipients' side, I mean, even the local politicians, they saw them as experts because they had never had someone in the role of just trying to facilitate the discussion before. I mean,
they were empowered. They were empowered to take a role.
Yeah, which was not there in the beginning. But I mean, eventually these people started to actually intervene with one another. So yeah, it was a consequence of the project. But of course, when you start to get those type of coalitions going, that can result in so many different things, because people are sitting on a lot of different resources, know-how, experience, funding, whatever, but lots of different things. But they have to recognize that I don't sit with every answer to every question. Someone else.
And that's why I think this goes back to what Professor Agnes spoke about, the context. I mean, the deep context is known by the people.
And the multi-sectoriality. There is no single sector solution. And the academia need to be there, the research, etc., because they have to bring those tools that are going to improve health. But implementing that, they are certainly not the best. Take the people who you want to serve, they will tell you how to implement this good innovation or this old solution that you have.
Thanks.
Multi-sectorial approach.
Thank you. Kay, any comment from your end?
I will leave comment to others for this one.
Okay, because there are other issues than health that we happen to focus on, which is just fine, but equally complicated and equally important, of course. So any other questions from the chat or comments?
Not yet.
Not yet.
I just want to say very quick in relation to what Kay and Carl-Johan was talking about before, I mean, basic science. I mean, we should never start thinking that evidence is enough. So let's just hold back and not continue. I mean, we need to have basic scientists. I mean, they need to start trying to understand extremely tricky phenomena. So, I mean, as an implementation scientist, I would never start saying, hold back, stop doing research. I mean, you want to continue that. I mean, this is my personal beliefs is really that this is what what we need in order to combat climate change, etc. So we need to be able to have those two thoughts in the head at the same time. We need to continue doing basic science, ask very difficult questions. Some of the science will result in maybe zero, at least. I mean, you will find out that something didn't work, which is fine, which we also need to understand. But when the evidence is there, we need to also not only, I mean, of course, synthesize it and making it into meta-analysis, etc., and developing guidelines, make those as user-friendly as possible, that you can also use your end-line people to actually develop things so that they look a bit more appetizing. In Vietnam, I went to a clinic and I asked them, so do you have the national guideline? And then the midwife started looking somewhere, and then she found it under so the table was tilting, so she could find it because it was balancing the table at the antenatal clinic. And she said, oh, here it is. It's a 300-page document. That's not something which is extremely user-friendly for a health worker. It was used to make sure that the table was not tilting. But I mean, you really have to work together with midwives maybe then to say, how, in what format would this knowledge be presented so that you could actually make a lot of use of it?
Yeah, so this is a strategy, and I'm for the researchers, but the basic research are in the box number 1. The last box is health outcome, and in between you have all those implementation that need everybody. You know, you can research in your lab alone for 100 years, no problem, but you will never get health if it stays there.
That's true, but it's all interconnected in various ways, but we need all the links of a chain or whatever, web, I believe. Something else, Nina?
No, I think we should move.
Yes.
Maybe we should move straight to question number 3?
I think we will. So question number 2, I think we've spoken a bit about when it comes to obstacles and the like. So we'll just to save some time and to have more time for question number 3. So when it comes to really being successful in various ways, when it comes to implementation, what about other sciences, not only implementation science, which I presume utilize all of this in some way, but we point specifically at some of the social sciences and humanities, in this case, political sciences, diplomacy, and ethics. So comments on this, Kay.
I mean, as a lapsed social scientist, I will say that yes, the social sciences and other sciences are very important in making sure that the implementation challenge is solved. Because when we are talking about implementing policies and practices from the sciences, we're talking about people. We're talking about people's lives. And we've seen in this pandemic the importance of social and behavioral insights. If we are to really understand what motivates people to accept or not accept therapies or vaccines, we need social and behavioral insights if we're to understand the social systems that allow many groups in our societies to be underserved or not served at all by therapies and vaccines for COVID-19. So we keep returning to the pandemic as this prime example, because over the past year, it has shown us not the limitation, well, some of the limitations of basic science and medical research, because ultimately the results of medical research need to, of course, be implemented and need to benefit people. And we are social creatures, we live in social systems. So we need to understand, of course, people's beliefs, attitudes, how they organize their families, how they are perceived in society, if we're going to really go the last mile of implementation challenge to making sure that innovations do benefit people. So I welcome that conversation. I welcome having not only implementation scientists, but social scientists, humanists, and behavioral scientists collaborate on finding more effective ways to have innovations really benefit people.
So now you're 5 months into this new administration. So what will this new US government do when it comes to using exactly this to make smarter, let's say, decisions, or have decisions have impact? Is that something you work on actively? Because I think we can all observe that when you stack governmental, let's say, advisory bodies or recruit ministers for science, et cetera, it's not seldom that they come from the natural sciences or medical sciences, let's say, maybe less so from the social sciences. So what's your comment on this? Is this something you do actively think about, or that would be a good kind of thing, but we don't know how to do it?
No, I think it is something that we actively think about in terms of representing not only various disciplines, but also various sectors of society and groups in society. That's something that we want to be intentional when we have scientific or other advisory boards. And that's been a prime consideration of one of the policies OSTP is implementing in this administration, which is a policy on scientific integrity and evidence-based policymaking. We have to recognize that scientific evidence is an important part of evidence that is used in policymaking. And we also know that scientific advice has to have many qualities. Of course, it has to be rigorous, it has to be empirical, but scientific advice also has to be varied in who is giving that advice, what sectors of society they come from, which disciplines and understandings they come from. If we're going to have a holistic, useful evidence-based policymaking in the federal government.
Thank you. Anna, have you been thinking about this, how to use other knowledge sources and approaches? as the examples given. Do you hear us, Anna?
Oh, I heard Agnes. Sorry.
Sorry.
I mean, not specifically that I come to think about right now.
Well, I will go to Professor Agnes and you can think about it, because Professor Agnes has been a practicing politician. And I think you know a lot about what might convince or might be useful to influence decision makers at that level. Could you reflect on that? Or is it just simply some people get it and get it done? What would you?
No. They are principle again, because for me, implementation is a science. Like there is also basic science, but implementation, like I say, you need to evidence the problem, and for this you need basic science, you need epidemiologists, you need statisticians, etc. And you need to prepare your response, and for this, and create the strategy for that. For this you need sociologists, anthropologists, people who are expert in culture and adaptation, etc. So you need, before you have a brief with evidence, facts, and you need in your brief the input of sociologists, how to get there, and also the input of the people you want to serve, how they will take it and how they advise you to proceed to implement that. After that, you need financial people, how you're going to sustain that. And the first step is to put that in policy, protocol, and guidelines. And after that, in the budget, you need the finance. So you need all a spectrum of expert and science to succeed. From the discovery of the problem, the solution, again, to the health outcome you want, passing through the right strategies, and be flexible enough to adapt yourself, and never forget the long-run solution, sustainment.
Professor Agnes, I think when we spoke some weeks back, you mentioned one particular example, if I am not wrong, about child and maternal care in Rwanda. And could you give us an example how that, under your ministry, somehow was changed, and how and why not before, so to speak? Am I correct there?
Can I give the example of HPV vaccine?
Please.
First of all, we need this genius who have discovered that. I think it's in Australia, you know? So you have, and after that, the woman in Rwanda didn't know that didn't know what cancer was. Due to the evolution, we were fighting malaria, HIV, TB. So people were surviving and start dying later with other disease, cancer. So we explained to the woman there are two types of cancer that are the majority for the woman. One of them is the cervical cancer that kills as much as maternal death. What is a cervix? They knew they had an uterus, but we never talked about, because of maternal health and rupture of uterus, etc. They knew. So we had to explain what is a cervix. We had to explain what is a cancer. We didn't went to the woman directly because it's complicated. We went to the pastors, the media, the parliamentarian, the local leaders, the teachers, when everybody was informed. Then we start informing the population, because the population don't come to a woman like me. They go to the pastor. It's true that I have a cervix? And the pastor have to say, yes, God give you a cervix, my dear, and you have to protect your cervix. Mm-hmm. And after we have an injection we can give before sexual intercourse, and it will protect your girl against that. 96% of voluntary vaccination. Just because we use the context, the behavioral change strategies, the leaders, the people who can influence your judgment, and the people who have the trust. If I'm going and talk about service directly to a woman in a village, she will look at me and say, wait, this woman from the city coming up. But if the pastor talk to her, she say, oh, I have one. Let's protect it.
Yeah, that's very illustrative, I think, by trying to understand who might be the influencers in the local community. And I presume, Anna, that you've experienced this as well, both in Uganda and in Vietnam, as well as in Sweden.
Absolutely. Yeah, absolutely. I mean, in Uganda, it was a tricky thing. I mean, in the 90s, when I started going to Uganda, I mean, speaking about HIV and condom use, because using condoms was not something that everyone wanted to speak about. But then you have very famous musicians who came out as HIV positives and started speaking about using condoms themselves. I mean, they were much more influential than many others. So yeah. Definitely. I've been sitting and thinking a little bit about, in addition to what, I mean, we have been trying to respond to question 3 now, Carl-Johan, for a long time and skipping your other questions, but I've been trying to think about, I mean, other challenges or obstacles, as you put it, in terms of implementation. I think 2 things that are coming, and this is not only from the perspective of being a scientist and wanting people to continue funding the important work that we do, but when you introduce new things, so new guidelines, there's something around how we need to reflect around how people de-implement or like stop. Okay, so when you come with this new thing, then what is it that I should stop doing and why? So there's something around de-implementation and us seeing us as, you know, characters of habits that I think is still a challenge. That I see a lot. I have a few different examples of like how do we think about de-implementation. But another thing that Agnes also reminded me slightly of now when she was speaking was the need to adapt things that would come with. I mean, very often when you come to whatever community, they would say, oh, so you're coming with this. That might work for others, but not here. So the instinct is sort of not here. So question is, how do we provide better guidance on how to make appropriate adaptations? So what is the active ingredient in this practice that you come with now? What is the active ingredient that I cannot start adapting my way around? Because people make adaptations all the time. And there is always a risk that they adapt it to the level where the intervention is not as effective any longer. Maybe you have to work alongside with them to really see how they adapt. Maybe you need to provide better guidance, but I mean, adaptations happen. I would say in general, guidance on how to make adaptations are quite poor. If we really want people to use evidence, I think that's something that we need to think much more around how to give appropriate like evidence-based adaptation.
But didn't you yourself, Anna, say something in the beginning there about co-creation and the fact that if you involve people in the very, let's say, design of how it's implemented, then suddenly it becomes co-owned and they take ownership as well. So I think you were onto something there early.
Yeah, I hope so. But the problem is that even if you're in the northern of Vietnam, as an example, and then you co-create something that functions quite well there, and then you go to the southern part of Vietnam, it will actually be quite different. I mean, a lot, we cannot have, or at least so what I want as a scientist is not that we start thinking that implementation scientists or whoever should co-create things with people all over the globe. I mean, that's not feasible. I want us to build capacity for implementation out there, and we need them to also have the capacity to also do adaptations, because we cannot always work alongside. So there are a lot of things where, I mean, I think co-creation is important. I think we can inform a lot of the development of science in a better way by co-creating. But in the end of the day, there are so many other populations that I would never meet. But they also need to have the capabilities to do these adaptations.
Don't go and think them. They have scientists, you know. You may teach me something. I will teach the Rwandan, and the Rwanda will teach. No,
Agnes, I have not been working alone. I was the only person for Sweden. Then I had like 20 Vietnamese researchers. I'm thinking of myself as a part of the global village.
In the north of Rwanda, you are not going the same way than in the south. And people have to co-create in the north and in the south. I cannot bring something from a part of the country where the perception, the understanding, and all the social determinants of health are not exactly the same. What I want to say, Anna, whatever we do, if we don't co-create, people will not buy it willingly. And this doesn't last. The first step of sustainment is co-creation and ownership. Everywhere.
I think that you can use that, but I think that adaptation, because not everyone can develop all the types of science, but if you can, I mean, adaptations to me is a form of co-creating.
Yeah.
So you have evidence, and what I'm saying that you can do local adaptations. That's a way of involving people in making appropriate adaptations. I'm not co-creating the evidence as such.
No.
The evidence is there, but I'm adapting.
agree.
So I think we're maybe saying the same things, but using
Because I thought you meant co-creating the implementation and not
Yes.
the underlying evidence. So I think we spoke about implementation all the way. I want to ask Kay about another thing. You said from bed to bedside, and that's really, let's say, a quite orthodox way of looking at medical research, because we expect the patient to be in the bed.
Right.
And that's, of course, a very late stage of a process, I would say. And also that's where people were more commonly before, when, at least in the Swedish healthcare system, there were many more beds. Today, people are treated at home, and we try to avoid to put people in beds because that's not good for you. So I would like to change that wording, in a sense, somehow, from bench to life in general to society, because that's where I think prevention at least should go. So just a comment, your reflection on my comment.
No, that is a good reflection. It is an old metaphor that needs to be revamped, but of course it's alliterative and it's powerful.
It is.
And so we continue to use it, even though we understand that to really implement, scientific innovations, we need to look beyond a clinic or a hospital bed to, where people live and how people live. It's less poetic, perhaps.
Yeah, thanks. I want to ask another question on this, because the way we framed question number 3 is a lot about politically and practically possible. In the political practicalities or attractiveness, what about co-creation with decision makers that are not only policy makers at the civil servant level, but rather the political class, if we put it that way? So in Sweden, we happen to have 8 parties that sit in the parliament. And what about somehow training them on future decision making by understanding the implications? So have you thought about this, any one of you, to have co-creation exercises with future or current decision makers at the political level?
I think we need to teach them how to proceed. That means the principle. Don't go in detail. They will miss that, because I don't understand how you create a vaccine, but I understand how I have to implement it. That means I need some principle, and all politicians should have that, starting with data, evidence-based, accept co-creation, discussion, multi-sectoriality, put people together, those who will use it and those who influence them. Like an example of HPV vaccine, go to the religious, because in US, religious has put it down, for example. So principle, they should learn it. They should pass an exam.
Exactly. Now we're talking about learning, but I want to turn to Nina. Do we have any questions or comments?
I want to comment on that particular thing on politicians.
Yeah, sure. But do we have one?
No, I think you should give the last 2 minutes to the panelists.
So Anna, please.
No, I mean, when you're saying, I have a PhD student that I'm co-supervising at Karolinska Institutet, and her thesis is actually on educating politicians on evidence-based practice. I mean, what Agnes was saying, you have trained politicians, not always. Our political system is that you have people from, they might be plumbers and they're politicians. They make a lot of decisions. They don't know anything necessarily about health or evidence-based practice. And we have not invested in them to understand what evidence-based practice is. When we speak of it, they think, oh, this is something to do with research. But we're also picking up best practice and clinical, so there are lots of things that I think could be done there. And it's clear, we have just done a very small pilot in one municipality in Stockholm. It's clear that they're also quite eager to know how to do this type of steering the best, because they are put in pressure. Media is looking into what type of decisions they're making. But as a plumber and as a politician, I might not know what is best. So we also need to be very sort of humble in getting them together in the room and getting them to say, I don't know this, across their party lines, because they are also competing with one another. And also ensuring, so what's your role as a politician? What's your role in evidence-based practice? So I think this is something which is, in a way, in my head, extremely interesting to start working more with.
Link that with accountability.
Yes, that too. Accountability, responsibility, they're very, very important terms, but also learning. So with that, I think we should conclude and maybe make this a theme for an upcoming event, maybe the EuroScience Policy Forum 2023 or so. So I would like to thank the panel for your input, your thinking, and all your contributions, and also thank Nina for our co-hosting here, and also everybody attending. So look forward to seeing you next. Have a good evening. Thank you.